Okay, I'd like to thank everybody that's participating in this webinar. My name is Tom Licker. I'm the president of the American Biorecovery Association. We have Michelle Buggy from IAQA, David Krause from American Industrial Hygiene Association, and Scott Vogel from IAQA and ABRA. The reason for this virus is that there's been so many questions and so many unknowns in fear of the unknown regarding this coronavirus, and we hope that this webinar provides at least some clarification of what we're dealing with in the field and how to go about looking at the opportunities that may be hitting your pipeline regarding the coronavirus. So I want to introduce everybody to AIP. We are the allied industry partners. This consists of the American Biorecovery Association, ACGIH, American Industrial Hygiene Association, AIHA, EIA, IAQA, and NADCA. We all entered into an MOU together to form AIP, and we're really excited to bring a diversified look into the industry and how it's, how we can best address problems going forward, and get good information and education out to our constituents. So with that said, Michelle, if you could advance the slide. So today, we're talking about COVID-19 and its impact to our industry. Right now, everybody's asking, well, how is it transmitted? What's the risk in the environment? And how do I prevent, my staff or what are the best mitigation tools out there to prevent transmission? And as far as we know currently regarding the CoV or the SARS-CoV-2 virus, the transmission and how you get COVID-19 is mainly, and correct me if I'm wrong, Scott, but it's mainly transmitted from bodily fluids or mucosal secretions from coughing and sneezing, and being within that zone of influence and breathing that, or if you get it on your hands, touching your face and nose, soft tissues, is how this is transmitted. And Scott Vogel, I'm going to bring you in on this. Have you seen any evidence or support of transmission from environmental surfaces at this moment?
At this time, no, I haven't. But reading back to that, the thing that we're seeing, especially with first responders, if they're healthcare workers and they're front lines, aerosoling, using nebulizer, when you're intubating a patient, that is all possibilities, and that's high risk. But when you're out in the current world shopping, they're saying direct contact of 10 minutes or more with somebody puts you at a high risk to a higher risk. And this is what was just released by the CDC. This is what first responders, police, EMS, and response are going to, is if you have a direct contact with somebody within 6 feet for more than 10 minutes. Now, other than that, again, there's been reports that your shoes can contain it. There's multiple theories and things. Me personally, what I've been seeing in New York and New Jersey is more of a family-based spread, as I want to say. A lot of the friends that I know that have it, a lot of family members of, in-laws of my sisters and everybody. What we've seen is more of one person gets it, brings it home, family gets it, then aunts get it, then uncle. So it stays within that realm of creating in small clusters, and it makes it look like a bigger cluster. That's what I've been seeing. Now, the nursing homes, as you can see, is big, but most of the nursing homes I know are basically on quarantine So we don't know how they're spreading from patient to patient. We're actually assuming that maybe the employees are asymptomatic and they're actually spreading it. But right now, I've seen no real data on transfer of me touching a surface and getting it. Most of all, everything that I've been seeing can be traced back to someone or something, but that's on my end, and I'm not doing the research in the labs, but on everything that we've encountered, we can kind of trace back almost to why somebody got it and where they were.
Yes, well, what we're seeing, from my point of view as well, because Scott and I are both in the hot zone per se, along the I-95 corridor, in dealing with New York and the New Jersey metropolitan area, is that it's not that facility hygiene is important, or that the CDC or WHO is not saying that it's not possible to catch it from environmental surfaces. It very well could be, but there's just isn't any data out there right now to support that theory. But it's always good to stay diligent on your facility hygiene practices, especially hitting the high traffic touch points within a facility. You're looking at, and every facility is different when you look at it. You could have production facilities, you could have other essential businesses, and when you're looking at risk of transmission from environmental surfaces, the areas that are of major concern, if you want to advance the slide, Michelle, the areas of major concern are going to be areas that are essential businesses, where people are still required to congregate. And we've seen everything from 2 hours to 9 days. Is it still infectious in the air? And where does that factor into the risk pool? So there's a lot of people that are really scared of airborne transfer, because I don't even think that has been determined yet. It's not something that's being supported at the moment. But when you're looking at how contagious this thing is, and we discussed previously, how is this only, this slide here and this illustration to your left was put out, in early March, and they're now considering what's called the R0, which is a statistical mathematical term that is used to describe how many people are infected by one symptomatic or asymptomatic individual, and how many people will catch the disease from one sick person. So, Scott, we just learned that the data has been remined, and CDC is now saying that this is possibly exceeding the original 2003 SARS as far as the ability to infect people and its virulence. Can you comment on that?
Yeah, so there was a report yesterday that came out, or it was yesterday, a couple days ago, that the R0 value is looking at a 5.7. In a 5.7 issue, we would have to have a herd immunity of 82% to stop the spread. Now, when we were looking back in the day when we were dealing with the 1.2s, the 3s, herd immunity would have had to be at like 55% to really stop a curve. But right now, if we're dealing with the 5.7 R0 value, we're going to have to be dealing with about an 82 to 85% for herd immunity. So the problem now that comes is we're not going to be able to achieve that. So now that is very concerning. Now that is the new data that just came out, like I said, a day or two ago. I'm still looking into that and researching that a little bit more, but if that number holds true, then social distancing is key right now, because if it is that contagious, we have to make sure that we don't allow it to be that number. We need to be able to minimize that spread as quickly as we can, because if not, we're never going to get to the point of herd immunity at 82%. It's just too much in communities. You would infect way too many people and too many deaths.
Right. Well, we're also looking at dropping this R naught factor, as quickly as we can, and that is why the social distancing is being required by us. Now, David, do you have anything to add to this? Is what you're seeing in Florida and what they're doing in that area of the country?
Sure. I do appreciate the R naught factor, and it is somewhat of a circular argument. I believe that as we recognize this agent is much more infectious or contagious than initial thoughts were, that really does force us to re-examine the assumptions on whether this is airborne, as in droplet nuclei, whether this is infectious and remains infectious on surfaces for longer periods of time. And I would just caution that the data we have right now is very, very preliminary, very, very sparse. So, with such, with an increasing estimate of R naught, I think we really need to re-examine that, and it's more likely that this is infectious via multiple routes, droplet aerosols, fine aerosols generated from the respiratory system of infected pre-symptomatic, asymptomatic, and symptomatic individuals. And then the thing we can actually have some greater impact on is the ongoing cleaning and disinfecting of surfaces in high-touch areas and materials in occupied buildings, which I think that's an area which is not being fully taken advantage of at this time. And with the concept of us moving towards reopening schools and places of businesses, and with ongoing existing essential facilities operating, we've really got to start implementing a much more rigorous program.
Right. Well, a lot of people, you're seeing it down there as well, is that, we got two guys in a van and with some sort of sprayer in the back, advertising that they're doing disinfection work, which is, in a large part, quite fraudulent. And, it's happening everywhere, and misapplication, and we'll get to that later in the presentation, but misapplication of disinfectants, and it's running rampant. So, how does the consumer separate the guys who really know what they're doing in this situation with with the fly-by-nights? We got pest control companies popping up overnight, and they're saying that they're running thermal foggers and all this kind of stuff, and that's kind of, to me, that's kind of dangerous. Scott, you have something to say?
Yeah, it really is, and if it sounds too good to be true, it is.
It is. Yeah. Go ahead,
and
Scott.
one of the biggest things is, David, you knocked it right on the head there, is where without rapid tests. Now you got to realize the swabs are 60% accurate. So right now, like New Jersey just came out, starting tomorrow is the spit test, and then you have the rapid tests that are being 5, maybe 45 minutes till we get a really better testing procedure. Right now in New Jersey, we're not getting confirmation for 4 to 5 days. So from that person to be in the office, becoming systematic and getting symptoms, then staying home, getting tested, we're not really seeing receiving a call for proper cleaning or disinfection, anything you would like to call it. We're not seeing that for 4 to 5 days. So when I get a call, I try to encourage, you need to step up your cleaning procedures on a regular basis, not waiting for that call to say that somebody's positive. Some essential businesses are doing it, especially in New Jersey. Some businesses are completely doing exactly what needs to be doing, taking temperatures before you come into work, making sure you have no symptoms. If you're showing any symptoms, you're supposed to stay home. They're cleaning. You actually go through temps before you go in. do a medical evaluation before you go into the business. So there is a lot of good companies out there that's really performing great triage of people going into work to make sure that their risk mitigation is a lot lower, that there could be a case inside. But with asymptomatic people, there is still a chance. But the issue that I'm seeing is the only thing we're going to be able to do is really bring in a good and better protocol in cleaning. And I hope that will continue even after this, because unfortunately, we're still not getting the test results for 3 to 5 days.
Right.
So
There's
for 3 to 5 days,
yeah.
who's there? I mean, after 3 to 5 days, is it infectious if it's not? But at the same time, has the cleaning crew already cleaned all the high touch points already, you know? So that's realistically what I feel is more important, is by getting that protocol and that standard of cleaning on a regular basis instead of just calling when it's needed.
You're right. Well, there's a lot of complacency in regards to the cleaning industry and its importance in maintaining those high risk touch points. You know, are they cleaning 4 times a day? Are they touching them? I mean, we got public buildings where you're seeing a massive humanity, hospitals and other things. You know, just set aside all the public buildings with police officers and stuff like that, and you know, is cross contamination being kept up with?
Right.
Symptomatic or asymptomatic? So if you could advance the slide, Michelle.
There is one thing that, I mean, that's a bit of a recommendation that falls into the recommendations AIHA is about to come out with as well, is that we really need to move towards an ongoing treatment and cleaning and disinfection throughout the day in ongoing operations, and avoiding the you know, potential hazards and inefficiency of fogging or other types of unapproved and, you know, applications of viricides.
Well, if you look at the, you know, just environmental disinfection in general, you know, this is an envelope virus with fatty lipid, and they're generally easy to kill. You know, with that said, but you have to clean before you disinfect. You have to physically wipe down surfaces. Unless you've pre-tested them with ATP or something like that, and they've had your own cleaning crew go in there and do that, and then maybe you can apply you know, by fogging, or if you use electrostatic spraying, or you know, any other type of delivery system. You know, but what's the true clinical value of going after some of this work? And you know, I look at it, and I'm completely honest with my clients and say, you know, if you already had a positive, they've already transferred it to 3 or 5 people already, and you could have asymptomatic people in your building and not even know that they're shedding virus at this time. We just don't know, unless I'm in there all the time and contracted to be there to, you know, touch or wipe down surfaces in between. Every time someone touches it, you know, we're not really going to have a clinical impact on the spread of this bug. And
Tom, one of the other things to think about here is that this is just one of numerous mitigation measures. There's administrative measures that we talked about. There's engineering controls. There's PPE, and really you have to bring all those weapons to bear to make sure that you're doing what you can to minimize the risk.
Well, it's about risk mitigation, and a lot of people will call a third-party contractor for internal relations purposes. They want not that you're going to do any better than, you know, if they are following a good protocol for aseptic technique when they're cleaning, and a lot of them aren't because they just don't know any better. They're cleaning with the same rag from the beginning of the room to the end of the room, and dipping it back into clean disinfectant solution. But they want that third-party reassurance that they're going to call a contractor that really knows what they're doing in order to show their own employees and their internal staff that something was done up and above what their current protocol is, and it makes it's going to maybe a false sense of security in a way, but at least it calms nerves, and that's the perception that they want to put out. I talked about proper practices, as quarterly, using microfiber and using it in quarters, flipping, the aseptic technique, and like I said, a lot of people that are in your standard custodial practices really don't know cleaning for infection control, and I want to bring that point up, is that that takes some training and it takes some technique, and if you really don't know how to do that, or consider when you look at a building from an infection control standpoint. I mean, I see people painting walls with disinfectant out there, and doing nearly 100% terminal cleans on rooms, charging people an arm and a leg to do this kind of thing, and it really saddens me. But at the same time, hey, the people are getting their buildings cleaned, and they're getting that perception. And one of the things I wanted to point out here is that in this particular slide is that when this first started, people were being sprayed with disinfectants coming off of airplanes with just a paper mask on, and these disinfectants were hitting their skin. And folks, don't spray each other with disinfectants. You're going to do more harm to your pulmonary system than you would probably from the virus itself. So some things to think about. So, Michelle, please advance.
Hey, Tom, one of the things that I would like to also point out is, don't forget the OSHA did come out with the 3990, which
Yes.
is the guidance of preparing workplace for COVID. And in there, the first couple pages, it talks about implementing an infectious disease preparedness and response plan. And this is something that what David was just talking about, and you guys were talking about, is it hits on admin, engineering controls. It hits on from every aspect to high risk, medium risk, low risk of employees. So it's a good thing to physically have. I know most of the people in our industry, in the bio and infectious, we have built our own plans, but that is something to look at. Is again, the OSHA 3990 is the guidance for preparing workplaces and creating that infectious disease preparedness and response plan, and really incorporating everything we're talking about and everything that's going on. Because, not saying this will be the last time this happens, hopefully it will be, but realistically it probably won't be. So we need to really step up our game and make sure we have procedures and plans in place, so if it does happen, we know where to go next.
Yeah, well, we addressed that after the Ebola crisis, and I think you and I both talked about this before, that in a lot of cases people were hot to trot for the first month after the Ebola crisis or two. They wanted these pandemic preparedness plans in place and what have you, and then it just kind of fell off the radar. People became complacent, and the very fact that we are a reactive society instead of proactive society just puts this into play again. How many times do we need to get hit in the face before we learn? Just something to think about down the line. Now, EPA put out the N list, and initially it only had mainly disinfectants and products that were on there from the big box chemical companies, and but it has been amended. It has been addressed over the past month or so to include, I think, probably if you look at it, it's probably almost every disinfectant that has that viruside, or that at least a non-envelope virus or emerging pathogens claim. So if you need to look and see if your particular product and cleaner is valid for the SARS-CoV-2 virus, please have a look at the N list published by the United States EPA. Okay, please advance.
This is Dave Kress. I'd like to add one thing to that. It's really most important that you not just look at the safety data sheet, that you read and adhere to the label, and that consumers and building owners and employers also become aware and make sure that either their employees, their staff, their custodians or the third-party vendors providing services are also to that label.
Yeah, I mean, we're seeing people in our industry, just indiscriminately fogging peroxide and other things that they're trying to get their hands on. And most people that are out of our industry, really, it's mainly we got people doing thermal fogging, cold fogging, everything, and you could have they're saying they're disinfection, and but where's the proof? That's something we'll get to. So
yeah, I would like to give one piece of experience here. Having done this for over 25 years, having sat as an expert witness in numerous litigation cases, and reviewing this as both a consultant and as a public health official, I've seen more people injured, made ill, and even killed, buildings evacuated because of botched remediation, misapplication, misuse of chemicals. I've seen more of that due to the chemicals than to the original contaminants themselves. So people really just need to understand it's not a if a little is good, more is better.
Yeah, and once you get into HAZCOM and the right to know. So, for example, David, right on to your point is all our contractual agreements state a right to know where we have to have them sign off saying that they received the SDS sheets and they are aware of the product that will be used at their facilities and that they will share it with their employees if asked or if they need to. If there will be employees. Now, that's actually on our contractual agreement, and that's mainly because when you deal with right to know in certain states and with OSHA and everything, you really do not want an exposure to a level of like what we're using is in the ionized hydrogen peroxide. What is the limitations of that exposure? This is why we wear meters. So all of that needs to be addressed and said, and make sure that a client understands that the SDS sheet has to be given to them. They should sign off on it saying they received it, and they should now be able to put that in to their file so all of their employees are well aware of what we're using at their site.
Right. Well, we developed what was it, about 3 years ago, Scott, that ABRA got together in their technical advisory team. Previous slide, Michelle, please. And we did develop the BISRA document. So if you want to click on that hot link there, Michelle. This stands for Biorecovery Site Risk Assessment, and it was developed as a need to address. That's still not opening. It was developed as a need to address front-end management. Here we go. Of losses that are coming into the biorecovery community, and a lot of people don't know this, but a lot of the ABRA members have been responsible for the cleanup of everything from the 9/11 anthrax attacks to H1N1 to the enterovirus D68 scare, SARS, and the Ebola crisis, and now this. So we started to develop this matrix, and there are certain questions that a contractor needs to ask because their employees know what's going on in the field and what they're faced with. And so biosafety, we really dovetail biosafety and follow the biosafety guidelines published by NIH. There's Canadian ones, and there's also CDC and WHO. And these pathogens or these risks can be grouped into different categories. And so APSA, the American Biosafety Association, put out a risk group database. And SARS is considered a risk group 3. And we give you some example activities. And then we after we identified a risk group, if you could slide it down a little bit. You here have low impact, medium impact risk areas, and high risk high impact risk areas. And here's a series of questions, and then it takes you through the determination of work class or work scope. And whether you have a group 1, 2, 3, or 4 pathogen, and what type of job is it? Is it low risk? Are you just wiping down surfaces? And that's mainly what we are seeing right now. So we're categorizing this as group 3, 2. And so you set up your exclusion zone, start donning PPE, contain any gross contamination if you have any. That's in the event that you have any body fluids or whatever that haven't soaked through, where you don't have to do any advanced remedial or removal action. Charge single-use microfiber cloths with mild cleaner and disinfectant. Clean up any gross contamination, and this is where you're really hitting touch points. And then you want to discard cloths when you're visibly soiled if you reach 12 square feet. Determine if any staining has occurred that cannot be removed by chemical or manual labor. Some of these things may or may not apply to this, cleaning up a envelope virus here, but it really, really works well when you're considering the risks involved with cleaning up any or addressing most biosafety or public health issues. It's just not trauma. We also, consider tear gas and everything else in this document. And it's available for free on the ABRA website under the Education Guidelines and Standards page. There's a whole bunch of other great educational information regarding the fire recovery industry in there. So if we can go back to this slideshow, Michelle. So, we're going to, we advance past BISRA, and there's some HVAC considerations in BISRA as well regarding certain pathogens. Some will travel in currents, and maybe Dave can talk about his experience with HVAC systems and in regards to that. Dave, do you have any information you can add to that regarding infection control?
Sure. I'll say one of them is a recent event, actually at a state facility here in Florida, where someone had decided that they would contract with somebody to fog, as of yet, an undetermined chemical into the building, and it resulted in a smoke alarm being set off, a fire alarm, which means that it actually traveled into the ductwork and activated the in-duct smoke detector. So two big issues there. One, I don't think they intended to fumigate the ducts because they were line ducts and they shouldn't have been fumigated anyway. And nobody can still tell me what they were fumigating or fogging with. And it impacted a critical facility in the state of Florida. So that's I'll say low-hanging fruit, simple oversight that should have never happened, yet
right.
Affected a facility that was needed for operations.
Sure, you have chemical sensitivities.
Everything about that is high risk, and adversely impacted the state's ability to respond to the current crisis.
Right.
So even presumably sophisticated building operators can make those mistakes right now. The second thing is within HVAC systems, pressure control, preventing them from being inadvertently contaminated, and to ensure that they're not moving virus or overcoming pressure differentials in healthcare and non-healthcare facilities alike is very critical. But right now, we don't really have any evidence that treating of the HVAC systems is necessary, needed, or appropriate with respect to the virus.
Thank you.
And I hope that people can avoid that.
Yeah. Well, like I said, it's the more we're more worried about the facilities such as clinics and healthcare facilities in that regard, and most of those facilities, especially if they're older, I've been in some of them where the engineers that are operating the facility directors don't even know where their cold air returns really are. So it does present challenges. So if you could advance the slide, Michelle. So clearance testing or no clearance testing, this has really come up recently. Some people have developed their own ways of testing surfaces, and what's the clinical value of it if you have a whole bunch of asymptomatic people that could be still running around shedding virus? Again, I don't know what you guys think, but personally, I think it's another, if it makes you feel better that you got clearance testing at the time, but also at the back end of this, what liability is the consultant taking by doing clearance testing with something that's so virulent and people begin running around asymptomatic? We have to worry about the speed of results and bias. Statistically, how many samples do you need in order to really generate a defensible report? I don't know, that's in PCR testing, RT-PCR is really only going to pick up the RNA or pieces, that are just pieces of the virus that, could have been, long, the virus could have been long dead, deactivated in a scientific manner. But well, Dave, what do you think of this?
Go ahead, please.
Go ahead, Dave.
Well, this is a highly evolving situation here. And I think really people need to really differentiate between verification and validation. And verification testing is a tool that can be used for both evaluating performance and adherence to protocols and procedures, as well as training to improve the efficacy and safety of people doing the regular cleaning or disinfection. Validation testing is really intended and should be designed to determine if what you're doing is achieving your goal, and establishing what that goal is. So testing is a critical component of this, but I think this is a problem that's going to be a short-lived one. I'm aware of at least one laboratory that is released just within the past 24 hours a PCR, commercially available PCR test for COVID, for SARS-CoV-2 that they've developed and validated on some of the cruise ships. And I too am always very cautious about using PCR as a test method because, like we said, it is detecting the genetic components. In looking at this and actually speaking with laboratories, there is a consideration here. One, it's not mold or bacteria, which, the question of is it alive, is it growing, is it amplifying? That's a different question here. For viruses, it's not alive outside the body anyway. It's not going to amplify there. But they make a good point in that the major components of the virus, the RNA, which is what you're detecting, is surrounded by a capsid, which is surrounded by an envelope, which also has proteins and materials that for the receptors, the envelope receptors.
Right, and all that has to exist in order to cause an active infection.
Exactly. And the one thing that they do point out is that capsid and that envelope are frankly much more resilient than the RNA. And that if your cleaning and disinfection processes have disrupted the exterior envelope and capsid of the virus, it would have disrupted the RNA, which is very fragile. So if you're still detecting the long strands of RNA, then it's likely that the other components of the virus are still functioning. And it's a conservative assumption to say that the material is still potentially infectious. So I do
Right.
see a value in it. It really needs to be validated. It really needs to have some buttresses put around it as far as how much testing do you need to do, how do you interpret the results. But I think we're moving in that direction pretty rapidly, and I think
Well,
as an aspect, it may be useful.
well, yes, I don't disagree with you, but it does definitely has to be peer reviewed for value in the marketplace. And right now, with most of the scientific studies of this virus remaining infectious on surfaces, maybe at 3 to 5 days at the most. And they found on the Princess cruise ship that the evidence of RNA 17 days after everybody left. So, I don't, yeah, it's a tough call for a client to really want to spend the money in doing this. And that's why I think it's more,
and I think
yeah,
that type of testing may fall into the realm of validation. Are you making the surfaces no longer infectious? But we still have the potential for verification.
right.
Are people doing all the steps they're supposed to do? Are they cleaning and disinfecting all the areas they need to clean? And there are ways and metrics to evaluate that.
Well, that's where the use of biological indicators can come in. This is very expensive to do because this is how we validate sterilization in pharmaceutical labs and aseptic pores and whatnot in clean rooms. But I think that the use of biological indicators to validate or make sure that the efficacy that you are claiming to do for that client is there. So a lot of people don't know what biological indicators are yet in this realm. And I know that some people are trying to develop some that have a gram-positive bacteria on it at 6 log or whatever. And I think that might be something to utilize down the road. But if you're only using the bacteria, which on the Spalding scale is just above what virus is, I'd rather see something that's a little bit more difficult to kill than bacteria, just to validate that the disinfection cycle or that disinfection has taken place on that surface. So I think it's going to rapidly develop. So next slide, please. We're just running low on time. So reason for social distancing, and we just wanted to reiterate this, is the fact that the flatten the curve, so healthcare and the morgues don't get overrun in a lot of cases when you're looking at a pandemic, especially something that's virulent. I look at this and I said, man, can you imagine if we had air travel and public transportation during the 1819 Spanish flu outbreak, and what that curve would actually look like? A lot more people would have been dead just due to public transportation, air travel and buses and trains. So right now we are starting to flatten this curve in the New York area, and it's starting to look promising. Not that we should be cavalier or complacent about the need for social distancing, but I think that it's proving to have its value, definitely in reducing the number of cases coming in and the number of deaths overall. So this is nothing that this country or the world in this generation or multiple generations has ever had to deal with. And it does have its economic damages. So, Scott, I know that you've been studying this quite a bit. Can you elaborate on this a little bit?
Just the mere fact of social distancing and flattening the curve. I mean, what we're seeing is, as you said, the curve is definitely lightening up, even in the United States, if you look at the overall numbers. But again, what I brought back and what we've been kind of talking about this whole show is how infectious and how this spreads. And right now, there's so much information out there that you can study, and you think you know, and then all of a sudden tomorrow a whole nother realm comes out, and it's like, oh crud, I'm totally, off my meds at that point. Like now there's studies saying 12 feet, 6 feet.
Yeah.
I know that what we're doing in New Jersey is definitely working, but again, I mean, the aspect of social distancing and anything that we do is extremely important. And with now the correlation of, or the collaboration of the kind of the Northeast about bringing in not one state, but 3, 4, 5 states about opening the economy, that's extremely important as well, because you're not going to want to just open the economy. We're going to have to do soft openings and kind of slowly go into it so you don't have a second wave, just like the
Korea.
like the Spanish flu of 1918, where 4,100 people died in 5 days after having the parade in Philadelphia. So we don't really want to do that per se, but what we want to do is kind of ease into it, incorporating mask wearing and social distancing as we go in. Maybe not opening nightclubs, but we want to kind of ease into it instead of just opening the economy and just going all for the three, like the whole free fall going in there.
Right. Well, I think people want to get back to work too. I mean, that's one of the most important things. I mean, I haven't been able to get a haircut in 3 weeks, and I look like a chia pet right now. So,
But see,
Join the club.
and that's
Join
the
the
thing.
club, Tom.
This is a really good what you just said, and the economy versus deaths. And I've been into this argument with a few people already regarding this. Is no death is okay. No one dying is okay. But when we're opening up, we're going to have to expect that you're going to have small clusters. So maybe allowing businesses, to encourage working from home, which I think will be kind of the new industry standard going forward as well, because this has been carrying on for so long. I think companies might see some validation in letting their people work from home. But also, do we require businesses open to the public require masks still?
Oh, absolutely.
So
Absolutely.
this is
Yeah.
where,
Well, but there's another aspect here to consider, that while there is a spotlight on the Northeast, on New York, New Jersey, as well as California, but this has not yet hit Middle America.
nope.
Right.
I can tell you that there are still very full Walmarts and grocery stores where very few people are wearing masks in Georgia and in Alabama and in Florida, and we will likely see ongoing clusters and outbreaks as we move forward, because still some states still have not implemented any stay-at-home orders.
Right. I
So
mean, they're very complacent to it. So I mean,
But see, you also have to look at the density aspect of that as well. Does these areas, for example, even if you look at New Jersey, okay, and you look at that, most of the areas that are hitting have direct train lines to New York City. Most of them are current where the population uses mass transit, where when you start going to South Jersey and you go out west of Jersey, people that do not use and do not rely on mass transit, you've seen the numbers. Now, yes, it could be the lack of testing, but you've seen the amount of deaths, and you've seen the amount of cases not rise to the level of a dense population that uses mass transit and certain other means, because the social distancing aspect might already be there in them areas, just not as big as they are in the dense population of like New York City, where
and those populations also don't have the same ratio of hospitals, intensive care beds. They are much more at risk if and when they become ill of experiencing adverse effects. And then you do have the situation in Sioux Falls, South Dakota, in the
plant,
Smithfield plant, where the vast majority of cases in the state are attributed to a single workplace, and they've had to shut down.
or a single worker that went to New York for a little vacation and came back. I mean, that's how quickly this thing has spread. And when we were looking at the original R0s on this, I was like, there's no way. This thing's moving way too fast.
Exactly.
So, Michelle, if you could advance the slide. So, we have to look at exposure and presumptive and positive cases. Like I said, a lot of them are preventative public relations issues, internal relations issues. You have to look at institutional, the colleges and universities which have shut down, transportation. We're discussing the biggest thing that is the biggest risk to transmission out there, and that is public transportation. Quarantine areas, quarantine units that are on bases are very high risk for transmission from either environmental surfaces or from person to person. Healthcare facilities. People are going to these places because they are sick. Not a place that I would take lightly going into without PPE or other environmental health and safety considerations to mitigate you from getting the disease. And we're going to talk about an emergency response. Presumptive, Scott and I get a lot of calls for presumptives and positive cases. Pretty much that's nearly 100% of our business. These are high-risk facilities. They're facilities that have to stay open in a lot of cases. And like Scott said, by the time they've called with someone that has an illness, that now with the 5.75 people have already contracted it.
Too little, too late.
It's a little bit too late, but still, if you could, advance the slide, please, Michelle. And now we're going to talk about recovering from COVID-19 building closures. And I'd like Dave to take this because it's a very important part of where we get from point A to point B. Go ahead, Dave.
Certainly. Thank you. This has been a recognition by the Indoor Environmental Quality Committee of the American Industrial Hygiene Association. These recommendations that I'm going to discuss here briefly have also been recognized by the Centers for Disease Control and Prevention, and they put out some guidance on this as well. And then Washington State Department of Health is also issuing guidance on how do we turn back our buildings? How do we reoccupy these facilities? Because one of the major risk factors for Legionnaire's disease outbreaks is disruption in water service. Building water systems that basically sit stagnant for periods of time, which allows for waterborne chlorine to dissipate and waterborne pathogens to amplify. And one of the cruel ironies and coincidental problems here is that the symptoms and the signs and symptoms of COVID-19 parallel and mimic those of Legionnaire's disease.
Sure.
You're talking pneumonias, cough, fever, and it's not something that is rapidly detected by other tests, by a standard test. You have to test specifically for Legionnaire's. So one of our concerns is that with the rapid shutting down, the warming temperatures, and the stagnant water in large swaths of American buildings, that we may go back into these buildings, turn on the water, and experience significant number of outbreaks of Legionnaire's disease. Now, Legionnaire's disease has increased by 650% over the past 15 years, hit over almost 10,000 cases in 2018. And I do have concerns that what we need to do is recognize this issue and take proactive steps before buildings are turned on, before they're reoccupied, before the cooling towers go back into full operations, that there be a proactive cleaning, disinfection, hyperchlorination of those systems to at least knock down or push back or potentially even disinfect those ticking time bombs.
Well, we were running into it, Dave, when the public health officials wanted to reopen these shuttered hospitals and healthcare facilities, even some mental health facilities, and use them as quarantine space. And it hadn't, one of them hadn't been open for 12 years. And
you just cannot do that.
Put the brakes on this thing, because and think of the exposure risks that you're potentially exposing people with compromised immune conditions to. Not only that, but you're talking about a bug that is a killer, and
yeah, I mean, there you're talking a 10 to 25% mortality rate.
Right. I mean, why would so, but we were saying, hey, let's put the brakes on this thing and really rethink this. And in a lot of cases, they heeded our advice. So, with that said, be very careful about, all of a sudden, they're in desperation mode, and they're going to be opening quarantine centers in buildings that have been abandoned or haven't been used in a while, and that presents itself a major health risk.
Yes, that's a recipe for disaster. The other aspect that we're concerned with is the essentially shutting down of HVAC systems, or running an HVAC system without the normal heat load from occupants, which can allow for mold growth to occur both within the occupied spaces and the HVAC system, ducts, and air handling systems themselves. So, continuing to operate buildings, continuing to flush their water systems, continuing to keep them conditioned is critical in order for building owners to be able to come back in, turn on the lights, and not have to just step directly into a remediation activity, which may postpone their reoccupancy of their buildings for months.
Well, we ran into that with the school systems every August. So
yeah,
in the Northeast, it's like automatic mold remediation work. So that's definitely these are just things that we run.
AIHA has posted some guidance on this, and we'll be posting some additional guidance on disinfection processes and considerations for protecting the health and safety of both your workers and your patients, clients, or customers in buildings that have been shut down during COVID-19 response.
Beautiful. And that can be found on the AIHA website?
Exactly. If you can see at the bottom of the page here, there's a link to that document.
Beautiful. Thank you, David.
Thank you.
Okay, Michelle, advance. So we talked about some of the potential legal exposures. Do you need language in your contracts to prevent you from subsequent health risks? Always have something. Have your attorneys go over your contracts and make sure that there's, you're properly indemnified as a contractor. Are there Department of Labor laws that pertain to emergency response actions? Absolutely. You have OSHA HAZWOPER, you have bloodborne pathogen standard, and all employers have to adhere to the general duty clause. Scott, could you talk about this a little bit, because this is something that our industry seems to struggle with?
Yeah, so there's a lot of conflicting information, even within the industry professionals, about the risk mitigation and the level of training requirements of us actually going in there. Does a 40-hour HAZWOPER require? Does a 24 general site? Does BBP? But at the end of the day, it comes back to the general duty clause. So I wrote a letter of interpretation for OSHA, which is published. They put on their art about if our industry is needed to have a 40-hour HAZWOPER. Being OSHA who OSHA is, they wrote it very cryptic and left the letter of interpretation up for interpretation. So basically what it comes down to is if there's an incident, or if there's a national disaster or an emergency that is declared, then a 40-hour HAZWOPER would be required. But then there's going on to further, and there's been challenges of, well, janitorial companies, or nursing hospital staff that cleans up. Do they need 40 hours? No, they wouldn't. But in the general sense, I would look at this as it falls to the general duty clause and how you're responding as a contractor or a mitigator. if you're selling yourself as going into a job mitigating due to an emergency situation, you are responding to an unknown threat. Even though it's the SARS-CoV-2 decon, you are still responding to that as an outside vendor and have no present knowledge of in that space. Now, by saying that, I would 100% agree and assume that a 40-hour HAZWOPER would be required, because in my perception, you are now going into a place and you need to do risk assessments, you need to do site surveying, you need to understand that site. And it's not like you're going in and bidding a job and you're starting it 6 months from now. No, you are getting calls from a client saying that this is a need, this is an emergency, and they need you now. And if you're responding, then all your technicians should be capable of being trained in a 40-hour HAZWOPER with 3 days of on-site training, supervised training. So now your 1910-1030, your bloodborne pathogen standard, says that everything is universal. Your universal precautions means that everything is infectious. Now, we already know this is highly infectious. So we already know there's a level of uncertainty. There is no unknown treatment for it as well. There's no treatment. There's only a kind of care, supportive care for this. So till there's a treatment, or till there's even a better line of supportive care, I would say more of a treatment base actually, I would say then you would have to treat this as going in there with the 40-hour HAZWOPER, with some type of understanding of infectious disease as well as bloodborne pathogens. And then at the end of the day, if somebody gets sick, it's going to be really hard to prove that it was on job site. But I feel like it would be challenged. And if the protocols and training were not put in place, I think then OSHA would always fall back on the general duty clause anyway, saying that the lack of training was a reason of this person could possibly get sick. And it could have been a possibility on a job site. And in that point, I would feel like more employees or contractors right now, what they're doing is they're just hiring to meet the demand, but they're really not training. And David mentioned the SDS, the right to know, HAZCOM, PPE, respiratory fit testing. All of these are requirements. And the problem is I don't think a lot of companies know what they're dealing with when they're going into this, because
well, it's not necessarily the companies, it's their, not only the company, but it's their employees don't know.
Yeah,
that's the scary part. So, you know, with that said, there is exposure to HAZWOPER here because, correct me if I'm wrong, but aren't biologics considered, or biohazards, infectious, materials considered hazardous substances?
Yes, and that's the thing. So in all honesty, yeah, OSHA does declare it as a hazardous substance. So realistically, it would fall under a hazardous substance, which would be in the definition of the 120 and HAZWOPER. So that's where it would all fall. And again, it's not going to matter if nobody gets hurt, because realistically, nobody gets hurt. It's going to be at the back end when somebody gets hurt and there's going to be a case, and that's what's going to end up happening.
Right. Okay. Go ahead, advance the slide, Michelle. So we have, I laughed at somebody posted this, Facebook certified expert in infectious diseases. And I wanted to bring up the medicine men, the charlatans of the industry. And all of a sudden, everybody is an epidemiologist or environmental disinfection expert overnight. We've heard reports of door-to-door imposters selling everything from testing to disinfection, and we just want people to be aware of those who advertise the following, use the words, sanitize, disinfect, sterilize, eradicate, because they really can't. There's no proof in them being able to perform that unless you are using validation on the back end. And the only way to prove a disinfection cycle was successful and unbiased is by biological indicator testing currently. So, with that said, be very cautious of, who's advertising disinfection services on the sides of roads. We've seen it all. we feel that this needed to be properly addressed and brought to the attention of the public and people out there. I know most people that are in facility hygiene or industrial hygiene, biorecovery already know that this is occurring, and it's going to just open up the doors to liabilities, future liabilities down the road. So please be careful and do your due diligence on the contractors that you choose. Okay, go ahead and advance, Michelle. So this is my final statement with this is, hands. Wash your hands often. Train your children to wash their hands. Soap, and don't forget the soap, and water. And say the ABCs or the birthday song while you're washing your hands. Hand washing is probably the single most important thing that you can consider in the event of an outbreak, and probably the most valuable. Healthcare has dramatically dropped their healthcare-acquired infection rates just by simply hand washing. The soap, destroys fats and removes lipids and proteins, and the water carries it away. So, with that said, I'd like to thank everybody who participated in this webinar. I hope everybody learned a lot, and I'm looking forward to more webinars being produced by AIP. And thank you very much, everybody.